Plasmodia, and other blood and tissue protozoans. Amoebas infect humans primarily through direct invasion of mucous membranes, often when the individuals come into contact with contaminated water during activities like swimming. In contrast, many other protozoan parasites require an arthropod vector to serve as either an intermediate or definitive host for transmission to humans. For example, malaria is caused by the Plasmodium species, which are transmitted by Anopheles mosquitoes. African sleeping sickness results from the infection with Trypanosoma species spread by the tsetse fly. Babesiosis is caused by Babesia species, which are transmitted by ticks. These vectors play a critical role in the life cycles and epidemiology of these protozoan diseases. Acanthamoeba and Naegleria fowleri are small, free-living amoeba commonly found in various environmental sources, including freshwater, soil, hot tubs, air conditioning systems, dust, air, and compost. These amoeba exist in amoebic form that can penetrate and infect mucous membranes, potentially spreading to the brain and central nervous system. Naegleria fowleri is the causative agent of primary amoebic meningoencephalitis, which is a rapidly progressive and usually fatal infection of the brain. In contrast, acanthamoeba causes granulomatous amoebic encephalitis, which is a more chronic and often fatal central nervous system infection, especially in the immunocompromised individuals. Naegleria fowleri infection is typically acquired by children and young adults who swim or dive in contaminated ponds or streams. The infective trophozoite form can be detected as motile organisms in wet mounts of cerebrospinal fluid during laboratory examination. Although infections with Naegleria fowleri are rare, they are almost always fatal due to the rapid progression of primary amoebic meningoencephalitis. Trypanosoma species are protozoan parasites transmitted to humans through the bite of blood-sucking arthropods. Two medically important species are the Trypanosoma brucei, which causes African sleeping sickness, and Trypanosoma cruzi, which is the agent of Chagas disease. These parasites rely on insect vectors for their life cycles and transmission, highlighting the critical role of vector control in preventing these diseases. Trypanosoma brucei is the causative agent of African sleeping sickness transmitted by the bite of the tsetse fly. After infection, the protozoan invades the blood and lymph nodes, leading to symptoms such as night sweats, high fever, and joint and muscle pain. If untreated, the disease progresses to a chronic stage characterized by neurological involvement, coma, and eventually death. Laboratory diagnosis is made by identifying trypanosomogotes in lymph node aspirates. Blood smears stained with Giemsa or right stain also reveal the presence of trypanosomogotes circulating in peripheral blood. Trypanosoma cruzi is the causative agent of Chagas disease. This is transmitted by the bite of the reduvid bug or the kissing bug. The bug typically bites the face at night, and the parasite enters the body when the bite site is scratched. Early symptoms include fever, headache, muscle aches, and cardiac abnormalities such as myocarditis and arrhythmias. Laboratory diagnosis is made by detecting trypanosomogotes in peripheral blood smears during the acute phase of infection. There are four main species of Plasmodium that can infect humans. So we have Plasmodium falciparum, ovale, vivax, and malariae. The parasite undergoes a sexual reproductive phase called sporogeny in its definitive host, which is the mosquito. In humans, the intermediate host reproduces asexually through a process called schizogeny. Infection begins when an infected mosquito bites a human, transmitting the parasite into the bloodstream and initiating the complex life cycle within that host. Schizogeny in Plasmodium life cycle. So the sporocyte stage of the Plasmodium resides in the salivary glands of the infected mosquito. When the mosquito bites a human, sporozoites enter the bloodstream and quickly travel to the liver, where they invade liver cells and undergo multiple fission, enlarging inside the hepatocytes. Infected liver cells eventually lyse, releasing merozoites into the bloodstream. These merozoites then invade the red blood cells, where they develop into the ring-stage trophozoites. Inside red blood cells, the parasite metabolizes hemoglobin and produces malarial pigment as a byproduct. The infected red blood cells later lyse, releasing more parasites and toxic byproducts into circulation, which contributes to the clinical symptoms of malaria. The body's reaction to the toxic byproducts released during the malaria parasite's life cycle results in shaking, chills, followed by a high fever. Patients may also experience flushed skin and pain in the back and limbs. As the fever subsides, the patient typically sweats profusely and then sleeps until the next fever episode, known as paroxysm. The frequency of these paroxysms varies depending on the Plasmodium species. Infections with Plasmodium vivax and Plasmodium ovale show a Tacherian pattern, with fever spikes occurring every third day, so about every 48 hours, whereas Plasmodium malariae causes a Quartan pattern with a fever every fourth day, or about every 72 hours. Some of the merozoites developing in red blood cells differentiate into male and female gametocytes, the sexual forms of the parasite. When a mosquito takes a blood meal from an infected human, it ingests these gametocytes, initiating the sporogeny phase, which is the sexual reproduction stage that occurs within the mosquito. This process leads to the formation of new sporozoites that migrate to the mosquito's salivary glands, ready to infect another human host. So it's important to differentiate Falciparum from the other species. Falciparum is the most severe, and the reason it is because it can infect red blood cells of any age. Doesn't matter if they're immature or mature. Babesia microti and Babesia equi are protozoan parasites that can incidentally infect humans, causing babesiosis. Babesia microti is the primary cause of human infection and is endemic in regions such as southern New England and Texas. The tick serves as the vector transmitting the parasite during blood meals. Once inside the human host, the protozoan invades red blood cells, where it produces ring-like structures that closely resemble those of the Plasmodium species, making microscopic differentiation important in diagnosis. Babesiosis is generally a self-limiting disease. Patients may experience symptoms similar to malaria, including fever, headache, and chills, but unlike malaria, babesiosis does not exhibit periodic fever recurrences. Laboratory diagnosis is primarily through examination of Giemsa-stained peripheral blood smears, with thick smears being more effective in early stages. A key distinguishing feature is that Babesia does not produce malarial pigment, helping differentiate it from Plasmodium infections microscopically. Toxoplasma gondii is an obligate intracellular parasite whose entire life cycle occurs in the gastrointestinal tract of its definitive host, the cat. It can also infect humans, causing the disease toxoplasmosis. In pregnant women, maternal infection can lead to fetal infection, resulting in congenital toxoplasmosis, which is a serious and often tragic condition. The parasite's life cycle includes three main stages: the oocyst, the trophozoite, and tissue cyst, which may play roles in transmission and pathogenesis. Infection with Toxoplasma gondii occurs primarily through ingestion of oocyst shed in the feces of infected cats or through consumption of tissue cyst in undercooked meat such as beef, pork, or bear. The disease presents in three main forms: a mild, self-limiting, or asymptomatic infection in healthy individuals. It could be a severe, often fatal infection in immunocompromised patients, particularly those with AIDS, where toxoplasmosis is a common cause of death. Or it could be a congenital infection, where the parasite invades the fetal central nervous system, with the severity of damage largely depending on the trimester during which the mother becomes infected. The parasite exists in three main morphological forms: the oocyst, which contains two immature sporocysts at its center; the trophozoite or troph stage, which is a crescent-shaped but cannot cause infection if ingested because it is destroyed by the digestive enzymes; the tissue cyst, which can survive passage through the digestive tract, although it is destroyed by freezing, thawing, or normal cooking temperatures. Laboratory diagnosis involves identifying the trophozoites in tissue using stains such as the Wright Giemsa or periodic acid shift stain. Additionally, serologic testing with ELISA is widely used to detect antibodies against toxoplasma. Human infection with Pneumocystis jirovecii is usually asymptomatic except in immunocompromised individuals such as premature infants AIDS patients, and those with leukemia. The trophozoite stage attaches to the host epithelial cells, while the cyst stage is infectious when inhaled. The lungs are the primary site of infection, although the organism can disseminate in severe cases. Laboratory diagnosis involves observing trophozoites or cysts in lung secretions or tissue sections. Common stains used to visualize the organism include gomorrhea, methenamine silver nitrate, Giemsa, and toluidine blue O. There are several specialized stains that are employed to detect these in clinical specimens, as the organism is difficult to visualize with other routine staining methods.